I would like to call upon Professor C.M.K. Reddy to give the presentation of Program on Communicative Skills in Medicine.
Respected dignitaries and dear friends, on behalf of Tamil Nadu Medical Practitioners Association and the Overseas Consultancy Enterprise, Limra, we welcome you for this second annual award function. I have chosen the subject of communications in medicine because you all know that it is a very important aspect that is unfortunately not taught in our curriculum. We all read the same book, pass the same examination, but then one man becomes very popular, one man becomes average. So what is the secret? The secret is communications. They have mastered the art of communication. So we think that this is a very important subject. I should convey to you what are the various issues involved in communication. So I have the first slide, please. We welcome our Honorable Vice Chancellor, His Highness the Prince of Arcot, and SRM Chairman Ravi Pachamuthu, Dr. J.S. Rajakumar, and all the other senior faculty members who are assembled here. One of the awardees was the Vice Chancellor at the time, Professor Mir Mahmood Mustafa. Medicine is an art because 50% of the diseases are self-limiting. So somebody said medicine is an art of entertaining the patient while nature cures them. So that means this is the very important art we all should master. Thambi, the ultimate aim of our medical science and art is a satisfied patient. This is the bottom line, and relieved of his illness. It's so advancing. This is the paradox. Science is advancing leaps and bounds. At the same time, the public dissatisfaction also is on the rise. This is the paradox. So why is this happening? Next. High expectations, because the science is advancing, the expectations are very high. Increased awareness of their rights, readily available information, aggressive marketing, suboptimal communicative skills, litigating tendency of the society, consumer activism, and of course, we have to acknowledge that we have a few black sheep in the profession. I suppose this is common to any profession, so we can't say that there is nobody in our profession too. That is why the result is individually we are very powerful. If you touch C.M.K. Reddy, he will explode. But then as a group we are weak. This is the issue. We all read the same book, pass the same exam, but one becomes very popular. Why? Communication, diplomacy, positive thinking, self-confidence, social consciousness, the delicate sense of humor, and a zeal to keep updated. These are the issues where people make a difference. There was a study done by an American psychologist, why doctors are being litigated. He examined over 100 cases that went to court, interviewed everybody, and came to the conclusion the main culprit was inadequate communication. So wherever there was a good communication, there is a little scope for litigation. And lack of transparency, this is another issue. These are the two issues which he raised. But Indian scenario, we have a third factor. I am sure all of you agree with me, there is a third factor, which is called the so-called one-upmanship. This is a loose, uncharitable remark made by a physician against the treatment given by somebody else. That sets the ball in motion. So this is a situation which we have to acknowledge. And unfortunately, we don't realize that tomorrow we may be in the receiving end. Today we may be on the other side. Tomorrow we may be on this side. So this is what is called, there is in legal parlor, there is one term called a benefit of doubt. That is, if there is a doubt in the evidence, whether it is to be accepted or not, the benefit is always given to the accused, and he is let out because they don't want to penalize him if the proof is not very clear. The same benefit of doubt we don't give to our colleagues is my question. We should give the same benefit of doubt to our own co-practitioners if there's been a situation which requires it. I have to give you an example. When I was young, even now I am young, uh, I used to call Professor Sarath Chandra for a second opinion whenever I had a problem. Very senior physician, very respectable man. We had a case of CA esophagus, and the patient was treated by a practitioner for about 3 to 4 months as acid peptic disease without doing any investigations. So ultimately they did the investigation and found the patient had a CA esophagus. So that was the case. I came to my room, we were sitting only two of us, nobody in the room. Now here I wanted to see the way I looked at it and the way he looked at it. I made a remark, it's a pity that 3-4 months they couldn't make a diagnosis. They missed the diagnosis for 3 to 4 months. So I was casting aspersions at the doctor who was treating earlier. Now, the way he looked at it was my eye opener. He said, you know, in a CA esophagus, probably it doesn't really matter. Even if I made a diagnosis 3 months earlier also, it would have made any difference. See, the way he looked at it, it was my eye opener. I made a mistake by making a remark. Then I had to withdraw my statement. This is what I want you to appreciate. This is that benefit of doubt. Communications can be 3 types. One is called the verbal, where you express in words, invite them by name. And a very important thing is, the patient is elderly, don't ask them how old are you, because they won't like it. Better to say what is your age, or even still better will be say how young are you. That is much better. And I have a small trick when the patient comes to my office. I usually start off with some non-medical conversation. Like suppose a girl, somebody accompanies them, what are you doing? I'm doing physics, BA physics. Oh, very good. Physics is my favorite subject. I used to get centum in physics. So what happens, you know, this brings you very close before you start off with the medical problem. So one statement unconnected to the disease, that brings them very close to the physician. This has been, I observed it and I find it very useful also. And of course, eliciting good history, physical findings also brings you close. Nowadays, we don't have time. The second is non-verbal, that is body language. Keep eye contact as much as possible. Assess their level of education, knowledge. Keep interruptions to minimum. You know, we keep on getting phone calls. As you're talking to the patient or discussing, keep getting phone calls, some nurse comes and disturbs you, keep them to the minimum, because an impression should be given to the patient that at that point of time, he is the most important person for us. This is the important point. And don't appear to be time conscious. Be prepared for some difficult encounters by insinuating questions, because nowadays they read the net, RVS, they read the net, they come fully prepared, and you know, sometimes they embarrass you by asking questions for which suddenly you may not be able to even answer. So, paraverbal, this is the third component. Behavior with our staff, behavior with the subordinates in the presence of the patient, because if you behave in a repulsive way, sometimes the patients will react. Don't criticize them or scold them openly in the presence of a patient. Don't mention about something that you had forgotten or acted in oversight. Then the patient may think that he may forget about your problem also. Don't discuss about a patient who was critically ill or expired. Address their emotions equally as good as the physical aspect. A good communicator can infuse great confidence and maintain healthy doctor-patient relationship. This is very important. This may also compensate, interestingly, of any deficiency in academic attributes. Then he will also become a good teacher. In fact, he may also become a good politician also. A good communicator become a good politician, because that is the first criteria for a politician. Watch your expressions, very, very important. Patient waits sometimes days and weeks to see us. Take an appointment and wait for a week to see us. And then every word we say will have a profound impact on his mindset. So they will keep thinking about it for the next 1 month. So it's very important that we watch our word, don't use any repulsive or unparliamentary words. A consultant, this was a study done, a consultant today spends 40% less time with the patient compared to 30 years ago. Because we are tight, hard pressed for time. How many of us routinely record blood pressure? Patient may come for something else. How many of us routinely record blood pressure? Just think, how many of us auscultate the chest, even though patient might have come for a hernia or a hemorrhoid, something. How many of us routinely auscultate the chest? Have glove in the consultation room to do a PV or a PR if necessary. So these things, not only for the diagnosis, it talks about the meticulous of our examination in the patient's mind. Patient thinks that this is a very meticulous man. He examines very thoroughly whatever the problem may be. Now, in most of the examinations abroad, in a clinical setup, communicative skills also are examined as a part of the clinical examination. They are given a dummy patient, and then patient is asked question, and the examiner will be watching how they are asking questions, what kind of questions they are asking, how they are behaving with the patient. So this is a part of the examination in most of the Western countries. We may have to deal with patients who is insecure, disappointed, agitated, hostile, depressed, financially broke, or he may be a court bird. So we have to handle all kinds of issues. Disclosing a bad news is another very important issue. You may have occasions where we may have to disclose a bad news. Consultation room, ward, operating room should be preferably disclosed by a senior member of the team. Release it in a phased manner, watching their reaction. We should focus not only on physical ailment, but also on their emotional reactions. Bad news, these are all the steps we follow. Make sure that you are very thorough with the case before you discuss with them, because suddenly you make some mistake in the findings, then the whole scenario will change. So make sure that you are thorough with the case. Sometimes you can use charts, pictures to explain to them. Discuss the treatment options. And then lastly, they will ask you, okay doctor, finally what do you think is going to happen? Just always leave a ray of hope under the pretext that biology is variable and unpredictable. We never know. Sometimes the medicine may work beyond our expectations. Worst situations in our clinical scenario, worst situation is declaring an unexpected death of a patient during anesthesia, surgery, or during delivery. This is a very worst situation to face. Fatal pulmonary embolus on the day the patient is supposed to be discharged. Patient requiring a second operation soon after the first operation. These are some of the critical situations where we face in practice. Sometimes it may be very genuinely required. This is the ABCD guidelines. You prepare well, suitable ambience, communicate facts and figures, deal with the emotional reaction, encourage free communication from the patient side also. Offer to get a second opinion if there is a potential litigation is suspected. A woman with her husband goes to a senior doctor. After taking the history, he says, "Madam, walk into the cubicle, I want to examine you." She says, she hesitates, and then she says, "Can my husband also come with me?" Doctor says, "What is this? You know me so long, I've been with you for 30 years, you don't have faith in me." "Illa sir, I have full faith in you, but there is a good looking receptionist sitting there. I don't want my husband to be sitting alone here." So there may be so many reasons why they ask so many questions. Now, olden days, this is another issue patients we have to face. The families were all attached and the bathrooms were detached. Nowadays, we have attached bathrooms but detached families. We don't even know where the son and daughter are living. We don't even know where they come when we die. We don't know anything. So this is the situation. Old parents are sitting somewhere here, and there is nobody to support them in emergencies. So this is the present scenario in many families. Don't give them false assurance. This is another place where we sometimes get into unpleasant situations because we give them false assurances. Medicine, we can't do miracles. There is a limit. One patient, there was a very critical situation where if you operate, 9 out of 10 die. So, whereas one doctor, after so many people refused to operate, but one fellow said, no, 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 I will operate, don't worry, the patient will survive. So the patient said, எப்படி சார் நீங்கள் அவ்வளோ கான்ஃபிடென்ட்டாக சொல்ல முடியும்னா, my last 9 patients died, so this must survive. Statistically, these should survive. So, it doesn't work like that. you can, yeah, woman in the 4th pregnancy. This is another where communication fails. Woman comes for the 4th delivery to an obstetrician. Because she delivered 3 children, they become little friendly, but that woman was not married. She was living with a man. So the lady, the doctor said, after all, you know, you have 4 children. You are living with that man. Why don't you get married and be done with it? He says, no, 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 I can't get married because I have a heart problem. So my doctor said I can lead a normal life, but I can't get married. So she's leading a normal life without getting married. That's a communication failure. Now, this is another point I want the senior doctors to invoke. Sometimes, you know, all of us drink the same water, but only one of us will get typhoid fever. Is it that only typhoid bacteria entered into his glass? No, all of us must have got it, but only one fellow gets the disease. So, this is what is called seed and soil theory. That is, the seed must be there and the soil also must be fertile to accept it. If that is not there, it will not germinate. So that theory sometimes helps us in explaining to the patient, yes sir, யாருக்கு வரல எனக்கு மட்டும் வந்ததுன்னா, this is, see, you are receptive to the problem, others are not. And biology is very variable. You can never guarantee anything in biology because, you know, you all know that penicillin can kill somebody, cure somebody. The same medicine can do different actions in different patients. So biology is very variable. Physics is very reproducible and absolutely concrete science. So you can't compare physics and biology. Respect the rights of the patient. This is another thing that we should remember. We should respect the rights of the patients, the privacy. They have the right to know all the details, risk of any procedure, accept or refuse, get a second opinion if they want, and get all the records, discharge summaries, investigations, and question the doctor or the hospital if the results are suboptimal. Because this, you know, doctor gets a phone call middle of the night. Doctor, I think my wife has appendicitis. Vaanga, konjam seekram vaanga. Doctor says nonsense. Last year only I removed your wife's appendix. Never heard of a second appendix. The other man says, doctor, have you heard of a second wife? That's what. Sometimes these things happen in our practice. Patient running away from the hospital. He goes to a small operating for a minor surgery. Before operation could be done, this fellow runs away from the theater. So outside, the friends are sitting now. They ask him, என்ன இது இவ்வளோ சின்ன ஆப்ரேஷன் நீங்கள் பயப்படி வெளிக்கு வந்தீங்க என்ன? அவர் சொல்லி, ஆமாம்மா உள்ள நர்ஸம் கூட அதே சொன்னாங்க, சின்ன ஆப்ரேஷன் ஏன் பயப்படுறீங்க? அப்போ ஏன் நீங்கள் வெளிக்கு வந்தீங்க? நர்ஸம் எனக்கு சொல்லலையா? நர்ஸம் டாக்டர் சொல்லியிருந்தாங்களா? இந்த சின்ன ஆப்ரேஷன் சார் ஏன் நீங்கள் பயப்படுறீங்க? So this fellow came running away. So be careful what you tell the patient. He says, doctor, I can't afford to pay and I have no insurance cover. Do you still think that I need the operation? He is asking. I think this is for Dr. Girnath. After major cardiac surgery, he comes out discussing with the relatives. Wife asks him, doctor, you've seen everything inside the heart? No, yeah, I've seen everything. Everything is fine. என் விட வேறு யாருன்னா இருக்காங்களா அந்த ஹார்ட் வந்து கேட்பான். Anybody other than me in this heart? So this is what the patient asks sometimes. Diplomacy. This is another thing very important. What is a diplomacy? A diplomat is one who tells you go to hell in such a manner you actually look forward for the trip. And you are saying irukku. The other thing is, if you meet a butcher, you talk about meat. If you meet a baker, you talk about bread. If both of them coming together, you talk about sandwiches. That is diplomacy. You talk what they are interested. Then another diplomacy is, I don't know how many of you know, Goddess Lakshmi has a sister. The sister is called Daridra Devata. That is the Goddess of poverty. That is her sister. So they both had a quarrel one day. Who is more beautiful? So they went to a businessman to ask, tell me who is more beautiful, Lakshmi or Daridra Devata? Now he doesn't want to get unfriendly with either of them because Lakshmi is very important and the other girl also is important. If she gives trouble, so This is where diplomacy comes. He says, Madam, he looks at Lakshmi, நீங்க வந்துட்டே இருந்தா ரொம்ப அழகா இருக்கிறீங்க. மேடம் நீங்க போயிட்டே இருந்தா ரொம்ப அழகா இருக்கிறீங்க. That is diplomacy. This is what you should learn in life. Without hurting anybody, both of them were very happy when he made that statement. Don't smoke. This is another thing. In an establishment, one manager found people were smoking while they are working. So when he sent a circular saying that nobody should smoke while working, they got all upset. Who are you? Tell me when we should smoke, when we should not smoke. So this fellow thought over a moment. Then he sent another, Ravi Shankar, I am a president, welcome. Then this man thought over this. Then he sent another circular saying, don't work while you are smoking. I have a right to tell you when you should work. No. So don't work while you are smoking. Then everybody stopped smoking. So this is a diplomacy. I remember when Dr. Venkateswamy, our senior plastic surgeon, was acting dean, Stanley, for some time. All the time our lifts were going out of order. So he suddenly figured that there is some fishy going on. That lift boy was creating some problem. When he wanted leave, he pull out some screw from there and say lift out of order, and so he goes away. So he realized it. So he found out a small tip how you could set this right. He called the lift boy and said, even if the lift is not working, you have a stool, sit here, tell all the doctors lift is not working. You can't go anywhere from here. From that day onwards, lift never went out of order. These are all very simple things. It may look very simple, but administrative. An orthopedic doctor says, don't bother, I will make you walk in a month. I'll make you walk in a month. You'll be very happy. So next month he comes and says, how are you? Yeah, I'm fine. I am able to walk because I sold my car to pay your bills. So now you made me walk. So now this is another press people also sometimes encounter. When I was giving an interview in Sun TV some time ago, the doctors were on strike. At the time, doctors were on strike. So for some issue, he thought that he will catch me there. I was answering all the questions. Finally, he said, Doctor, you are a leader for medical profession. What do you agree with what the doctors are? Professor K.K. Ramalingam, please come. Do you agree? Do you endorse the doctor's strike? It's a very sensitive matter because I can't go against our profession. At the same time, that fellow will not agree if I say, yeah, the doctors can go on strike. Now, this is where the diplomacy comes. This is where your communicative skills come. I told them, see, ours is a noble profession. We're not supposed to go on strike. But for a moment, let us look at their angle. The people who are going strike, let us see their angle. They must have had about maybe 10, 15 demands. And they must have given a notice 1 month in advance. It's not a lightning strike. So the government had all the time to discuss with them. Maybe 1 or 2 demands they could have conceded, and then at least 1 or 2 will be genuine. No? They would have conceded. Remaining, they have more time, they'll be definitely willing to do. They won't do that. They will wait till the strike commences. Then they'll say, you call off the strike and come for discussion. Why should that happen? Well, 1 month, what were they doing? So, it is not correct. They could have taken people like us into confidence because we tell them the students will listen. Senior teachers will tell them. Students sometimes take it seriously. So they can always take the help of us. They won't do that. So this is the issue. Now I think this is the reason the way they handle the strike is not good. Strike, of course, may be difficult for the public, but the government should have handled it more carefully and avoided the strike. This is what I said. So it is, I don't generate controversy. Sometimes, we had a patient who had a bilateral undescended testis, aged about 25 years, with azoospermia. Naturally, after the age of 12 years, if the testis is not come down, there'll be no count. But then the guy had a couple of children. The wife asked me, during some conversation, sir, how is it azoospermia? I have 2 children. Very sensitive question to answer. We don't know what happened, why he has the children. So, best is, I said, madam, it's very difficult to explain. Sometimes maybe it fluctuates. Sometimes it is there, sometimes it is not there. When we did the testing, it was not there. Maybe at some point of time it was there. So let us not worry about it. So you try to play cool instead of trying to create a problem in the family. It's very easy to create a problem in the family. Will I be able to play piano after the operation? Suppose he has a finger injury. She wants to know that she can play piano, but make sure before you are sure that she was able to play piano before the injury. That is very important. Informed consent. This is another thing. How much to inform? This is another area where there is a difficulty. There is always a debate how much to inform, because if you inform everything, sometimes the patients may have a second thought. So the rule of thumb is only probable complications need to be explained, not possible. Possible means everything is possible in the world. Probable, that means it becomes limited. That is the issue. Then patient has a right to inform refusal also. Now, will I be all right after surgery? This is another very delicate question. How can you be sure that everybody will be all right? Once again, I repeat that we should never give any assurances, particularly when it's a question of major surgery. I tell them, look, can you go to Central Station and come back? Give me a 100% guarantee. You can't do that. So if you can't do that, how can I give you a guarantee for a major procedure? It's not possible. There are many things can happen beyond our control. So we do it because the surgery is helpful to you, we are doing it. So there is always a element of risk. These are some of the questions. I remember when I was in training, I was assisting my chief for a mastectomy. What he did was he removed the breast mass, cut it, and thought, looks malignant. Anyway, sent it for frozen section. But before the report came, he already started doing the mastectomy. Though I asked him, you finished mastectomy by the time the report came, then why you wanted a frozen section? You know what he said? No, there is a point. He said, this is in Hopkins. He said, when I go out and talk to the relatives, it is much better to tell them I removed the breast because it was malignant than to say I removed the breast because I thought it was malignant. There is a difference, he said. So at least by the time I'll get the report. So, recently I saw one cartoon, a lawyer calling a doctor, I have very bad news for you. My client wants to include your parents also as accused. He strongly feels that they should not have sent you to medicine. Patient not willing for hernia surgery, we tell them go to hell. After explaining everything, still he is not willing. We tell him go to hell, but there is a caution. You tell him clearly he should go to hell only, not heaven, because if he wants to get operated, all surgeons will be in the hell only. If a surgeon says that it's a joke, somebody else says it's an insult. Maintain proper records, prompt reply, correspondence is very important. And even when I am sitting here, one patient calls me for some problem which we gave a prescription, it is important that we are available, at least on phone, to. This is a success story. You see, so much goes behind a success. Success, public see only that success line above the iceberg. But then so many things go before you reach that point. This is what we should realize. Ego. I think ego is something we should get rid of, this ego, because there is a writing on the graveyard. It says, all the people in this grave strongly believed that the world would not move without them. So, and patients don't take our advice seriously. They don't stop drinking, they don't stop smoking. So I have a way to tell them, look, I want to put a signboard outside. If every patient took my advice seriously, I wouldn't be able to build this building. So the message will go deep into their mind. Oh, adinala doctor building a kattara. So, twice. Now these are some of the expressions to be avoided. We'll move quickly. Cancer or malignancy is something patients don't want to listen. So you say tumor or a bad growth, or it may turn into something bad. Death is another word, they don't like it. Unfavorable outcome, or results may not be good. I'm going to give you a bad news. I'm afraid it's not going to be a good news. Prospects are very bad. Prospects are not so bright. 5% mortality. Instead of say 95% success. That is better. Be positive. 9 out of 20 lead a normal life. 19 out of 20. Nothing can be done. Let me check if something can be done to help him. Situation is hopeless. Science is so advanced, maybe we'll find some solution. In case of CA breast with axillary nodes, it is already in the second stage, is one way to say. Other way to say is, I am glad it is confined to breast and axilla only, it has not spread to other regions. This is a positive way. These are some of the words to be avoided in our summary, case summaries. Prospective organ donor. I heard Denton Cooley gave a talk when I was in resident. He was an alma mater of Hopkins. He came there after he did the first heart transplantation. He came and gave a talk. So he said they have a person named Hospital Vulture. Our job is any patient who is critically ill, likely to, not successful. This man will go and become very friendly with the family and try to help them out and slowly become very close to them. So at the time when the situation requires, he can moot the idea of giving an organ donation. So he is called Hospital Vulture. So that type of situation. Now I think we'll conclude because we're running short. There is a fundamental difference between Indian law and American law. I want to just draw your attention, then we'll close it. In American law, if somebody goes to litigation against a doctor, the contention of the patient is taken for granted. It is the doctor's burden of proof lies with the doctor to show that he has done the right thing. Whereas in Indian law is slightly different. If a registered medical practitioner, qualified practitioner, it is taken for granted that he has done the right thing. The burden of proof lies with the patient that he has not done the right thing. It makes a lot of difference. That is why I think the law is very conducive to the professionals in India compared to many countries. This is just I want to draw your attention. This is, my doctor says I can remove it, but my lawyer says I can't remove it. So, it's not the strongest or the most intelligent species that survive. It is the one most adaptive to change. They are able to change the circumstances. Have faith in adversities. Kindness is seen by a blind, heard by a deaf man. Ultimately, that's what matters. And there is finally this slokam always comes to our rescue. Karmanye vadikara, which means we only do the actions. He decides, the result he decides. So under that, we can always explain that we have limited control over the situation. Thank you. I think we'll stop here. Thank you very much.